Bonjour à toutes et à tous et bienvenue sur Kinédi. Aujourd'hui, j'ai le grand plaisir et l'immense honneur de vous présenter un épisode avec Mark Laslett, expert mondialement connu dans le domaine de la kinésithérapie. Mark est néo-zélandais et il a plus de 50 ans d'expérience dans le domaine de la kiné partout dans le monde. Mark va nous raconter tout son parcours qui, vous allez voir, est impressionnant et ses rencontres avec rien d'autre que Robin McKenzie et Mulligan, puis de sa recherche, son PhD, qu'il a commencé à l'âge de 51 ans. Mark nous explique la différence entre les douleurs lombaires spécifiques et non spécifiques et nous présente un tableau clinique afin d'y voir plus clair. Il nous décrit aussi comment il travaille dans son cabinet et nous explique comment il a obtenu son statut de physiothérapeute spécialisé en douleurs lombaires avec la mise en place de toute une communauté de thérapeutes pour soigner les patients atteints de ces douleurs. Alors cet épisode est divisé en deux parties, donc aujourd'hui je vous propose la première partie et la deuxième partie pour la semaine prochaine. Donc cet épisode est en anglais, mais pour ceux qui ne sont pas complètement à l'aise dans cette langue, je vous rassure, la traduction en français est prévue dès la semaine prochaine, donc restez à l'écoute. Hello Mark, thank you so much for accepting the invitation. How are you?
I'm well, thank you. You're most welcome.
Well, thank you so much. So actually, it's funny because there is a 12-hour time zone between France and New Zealand. So it's 9 a.m. for you and it's 9 p.m. for us.
It's bizarre, isn't it?
Very bizarre, yeah. So, Mark, for those of you who don't know you, even though a lot of us already know you because you're such a reference in the field of physiotherapy, can you introduce yourself and tell us about your experience?
Well, I'm old, so it's a long time. I graduated from physiotherapy and as a physiotherapist in 1971. So that's 53 years ago. And only 5 months after I graduated, I went into private practice on my own account. So I've been in continuous private practice, all except for 5 or 4 years from 1971 to the present day. The 5 years where I was not actually in my own practice, I was actually doing my PhD, and I was still seeing patients, of course.
Mm-hmm.
So I'm a clinician. I mean, it's my primary focus in life has been as a clinician.
Yes.
I became aware of science as such, as a sort of an important aspect of things in my early 20s, during the 1970s. And it became very clear to me that we were not taught, as you are today, not taught anything about science and scientific medicine. Mm. And we certainly did not get any training in the scientific method at physiotherapy school. There was no very little in the way of academic resources for reading other than textbooks and listening to people who had strong opinions, basically.
Mm-hmm.
So it was very much a profession, and medicine was too, by the way, very much a profession of eminence-based practice versus evidence-based practice. Mm-hmm. I think it's very important to realize that that's what I grew up with. Mm-hmm. Okay, and the next 20 years was a gradual exploration of not just science and medicine, but science in general. I actually went back I did part-time courses in the philosophy of science at the university, and I did extensive reading in epistemology and the scientific method during my late 20s and early 30s. So I wasn't just exploring physiotherapy and medicine. I was exploring the actual foundations of the method itself. Mm-hmm. Mm-hmm. And that, by the way, during the time it was rapidly exploring. And I remember very, very clearly the publication of the first systematic review which was in 1987.
Mm-hmm.
All right. So most people take systematic reviews for granted. We didn't have anybody synthesize the data at all on any subject prior to that time. So I've lived through that whole process of moving from eminence-based medicine through to evidence-based medicine, and I've been literally a part of it, really, of the growth of that new perspective. It's a new perspective.
Yes.
So I was in practice. I was extremely fortunate that in my last year of physiotherapy school, I spent a significant amount of time observing a doctor called Dr. Ian Broadfoot, who was a musculoskeletal specialist,
Mm-hmm.
and he had been trained by James Syriax and by Robert Main in Paris.
Mm-hmm.
So he got his diagnostic methodology from Syriax, and he got his manipulative therapy skills from Robert Main in Paris. And I was 20 years of age observing this guy, and I was instantly attracted to both manual therapy, manipulative therapies, and the actual process of structure and tissue diagnosis.
Mm-hmm. Yeah.
Before I even graduated as a physiotherapist. When I went into private practice later that year in 1971, we continued to get together every second week at the hospital in Auckland with Dr. Broadfoot and a small group of other doctors and physiotherapists, where we would talk about cases, talk about manipulation and practice manipulation. And by the time I was 22 years of age, I was a competent manipulative therapist. I didn't have a diploma or anything like that. I just knew how to manipulate every joint in the body, pretty much. Well, no, in the spine. I didn't have extremity joint manipulation training. I had spinal manipulation training.
Okay.
So I was quite comfortable with manipulating necks and thoracic spines and lumbar spines and sacroiliac joints and what I thought were sacroiliac joints and all those sorts of things. Then at that time, around about 1971, was the time when the New Zealand Manipulative Therapists Association was being formed, and the two instructors for that course were Robin McKenzie and Brian Mulligan.
Wow, what a duo.
Yeah. And the rules underlying your ability to start that diploma was that you had to be in practice for 2 years. Well, of course, I hadn't been in practice for 2 years, so I wasn't allowed to even begin the formal training because the rules didn't allow it. I was too young and I hadn't been in practice long enough. And McKenzie at the time was the president of the New Zealand Manipulative Therapists Association, who was running this course. So to cut a long story short, my first formally training by manual therapists was from Brian Mulligan on the extremities. And he was teaching the Carlton-born Evian system. That's the Nordic system. And that was very good, good training. We learned lots of different techniques and lots of different concepts about how to improve range of motion. I rapidly learned that the convex-concave rule, which was the foundation of the whole Nordic system, was great in theory, but not so flash in practice. All those stiff shoulders from frozen shoulders, I thought, oh, great, I've got a technique to fix those. And when I did all the tractions and the glidings and all those things that we were taught to do, it doesn't bloody well work. It didn't work. So I quickly learned the limitations of those approaches.
Oh, I see. Yeah.
So that was important. And then a year later, I started the spinal section of the course, which was run by McKenzie, and he also was teaching the Carlton-born Evian system. Most people don't realise that Robert McKenzie was first before he taught his own material. He was actually a teacher for the Nordic system. And he was very good. He was a very good manual therapist. But he didn't have to teach me manipulation because I was already skilled at that. By the time I started that in 1974, I think it was 1974, I was already able to do any manipulation that we were taught.
What was it like to meet Mulligan and McKenzie? How were they like?
Oh, they're very large life people. I mean, McKenzie was simultaneously imperious, like a very, very self-confident. He knew where he was coming from. He knew what he knew. He knew what he didn't know, and he did not suffer fools gladly at all. He, if you asked a stupid question, he'd say that is a dumb question, and he'd give you reasons why it's dumb.
Okay.
He was a very good teacher.
Yeah.
Actually, an outstanding teacher. He was an even better clinician. He was, so there's no question about that. Mulligan Brian Mulligan was an outstanding teacher. All right, but he was a completely different personality. He was a joker. He was constantly telling jokes and, doing a miracle every day. That went way back into the 70s. I mean, I don't know whether you've done a Mulligan course, but the miracle every day was, you're going to make somebody cure somebody today type of thing. I mean, he was a showman, absolute showman. McKenzie was not a showman, not like that. McKenzie was a person who would see patients in the clinic and see patients on courses. Mulligan never really did see a lot of patients on courses. He would treat people who are attending his courses, but they didn't bring in patients
I see.
to the course. Okay. McKenzie always wanted that because in his mind, there's no point in teaching something you don't do in practice.
True.
And so I was very much attracted to that very highly practical and pragmatic approach that McKenzie had. In the last year of my diploma in manipulative therapy course in 76, McKenzie started to introduce his own concepts. And there was no book. There was nothing written. It was just in his head. And I remember him putting up on the blackboard, posture, dysfunction, derangement. And his story about how meeting Mr. Smith, and he found that this rather not very bright man lay face down on a bed that was bent up and an extension, and how the leg pain centralized and he felt better almost immediately. And that was like a revelation to him that something so simple could be so effective type of thing.
Yeah, there's the story of, the patient that was left on the table.
Do you not know about that?
I do. Yeah.
Okay, that story he was telling that story in the middle 1970s.
Yeah.
That's not something that's I mean, he don't. I asked him. I says, "Was his name really Mr. Smith?" He says, "I have no idea."
Smith is a common name. It's easy.
For whatever, Yeah. I mean, Anyway, and in my 1976, having learned all these manipulations and listened and watched and worked with Brian and Robin in the class, I decided I needed to go down to spend time with McKenzie in his clinic. So I attended his clinic for a whole week, and I watched him in his clinic for a week in Wellington, because I live in Auckland at the time, and he was in Wellington.
Yeah, he's from New Zealand, like you.
Oh, yes. Yeah. Mulligan's also New Zealander.
Oh, yeah. Only the best from New Zealand.
Well, no, that's not true. But, we had a disproportionate number of significant people in our profession came from New Zealand. But there are plenty of other people around the world. But some of those were New Zealanders who had emigrated. Stanley Paris, for example, who was the person who started the whole manual therapy world and physiotherapy in the United States. He's actually a New Zealander.
All right.
Yeah. Anyway, so he was the first president of the International Federation of Manipulative Therapists, Stanley Paris, and he was a New Zealander from Dunedin.
Interesting.
I know Stanley, by the way. And by the way, I've just spoken with him only very recently. He's still alive. Anyway, and so is Brian Mulligan, by the way.
Oh, right.
Yeah, I last spoke with Brian, I think 2 years ago.
All right. Okay. Mm-hmm.
He's in a retirement home, but he's still, alive and well. I mean, he's fine. He's just old. Anyway, so then I went and watched McKenzie for a week, and then I was expecting to see all these manipulations that we had been practicing and he'd been teaching, and he didn't do much of it at all. He was just getting people to do these dumb exercises. And I was actually really disappointed for the first day. I thought, I've closed down my whole practice, and it's costing me a fortune to be here. And all he's doing is giving these people bloody press-ups and pulling their knees to the chest and stuff like that. And I didn't get it. I didn't get it at all. I was a manipulative therapist.
I see, yeah.
And then on Tuesday, the patients were coming back the next day, and patients were changing. And by Wednesday, I'm going, oh my God, some of these patients are really getting better very, very quickly. And by Thursday, I thought, holy shit, I should be here a month. And by Friday, I was convinced.
Patients would come in every single day?
Every day.
Every day for how long?
Oh, well, as long as it was necessary. But the number, you have to realize you cannot extract a person out of their time and look at them and say, and do judgments about. He was a man of his era, as was McKenzie, Mulligan, as was all of our physiotherapy colleagues. When I first went into private practice, I bought an existing practice with a big loan, I have to tell you. I didn't have any money.
Yeah.
He was one of the best physiotherapists in New Zealand at the time. His name was Leonard Ring. Mm-hmm. You won't know who he is.
No.
But the standard model was that the patients were all referred by doctors. We were not allowed to see patients off the street. And the prescription was for daily shortwave diathermy and massage for 6 weeks. And that's what people got.
That reminds me a little bit of a prescription we get in France from doctors.
Well, that was the thing McKenzie and Mulligan attempted to change. There were other teachers, by the way, too. We had about 5 or 6 top manual therapists in New Zealand. You've got to remember that at that time there was no more than about 1,500 physiotherapists, and we had maybe 10 or 15 world-class physiotherapists. And they formed the Manipulative Therapists Association in order to upskill our whole profession. Brian Mulligan and Robin McKenzie taught for 7 years, and all they asked for was to be given their travel expenses and their hotel expenses. And they traveled the length and breadth of New Zealand and taught for free.
Wow.
For 7 years. And there was an intentional gift to our profession.
Yeah.
To upskill our profession.
Absolutely.
Most people don't realize just the effort that went into changing how we did things.
Yeah. By
some of these key people, and Stanley Paris, although he don't think he did anything for free, he put in a fantastic amount of time and effort in the United States. Just a huge amount of time, and there were other people too. Jeffrey Maitland was the same, in Australia. I mean, he was an extraordinarily influential person, as you know. And people like Freddie Kaltenborn and Olaf Evianth and people like that, they travelled the length and breadth of the world, everywhere in the world to teach, just to upskill our profession. So our profession owes these manual therapists a huge debt. Mm-hmm. And I was one of the early recipients of that gift. there was a sort of there was a philosophy, if you like, a culture in our profession that we give back.
Mm-hmm. That's right. Yeah.
To our profession. Anyway, I started after watching McKenzie. I started modifying my treatment for the spine based upon his ideas, and I was meeting him on a regular basis. I'd call him probably every week, and we'd talk for an hour on the phone, which was very expensive at that time. And I would assist him when he was teaching at conferences all over New Zealand. And by the early 1980s, the McKenzie Institute was starting to form. He had already started teaching internationally in 1976, the same year that I graduated with my diploma in manipulative therapy. And he stopped teaching that year. I was in the last class he taught manual therapy to. And he started teaching his own material internationally. And as you know, he was a very, very prolific teacher.
Yes.
For probably 15 years. And to cut a long story short, the McKenzie Institute was formed. I was one of their primary initial teachers, along with a bunch of Americans, one or two people from Europe, and one or two from Australia, but mostly from New Zealand. And I started traveling to teach the McKenzie method in 1985.
Mm-hmm.
What happened in 1984, we had we got all the American physiotherapists who wanted to teach McKenzie to come out to New Zealand to be trained by the New Zealand manipulative therapists to do manual therapy.
Mm-hmm.
Because most of them were not manual therapists, but New Zealand McKenzie instructors were.
Mm-hmm.
We were all manual therapists.
Yeah.
And so to us, there was no conflict between manipulative therapies or manual therapies and McKenzie. It was but the difference was that McKenzie saw manipulation as a graduated endpoint.
That's right. Yeah.
Of loading joints and structures. Mm-hmm. Whereas the manual therapist went straight into there. McKenzie says no. I mean, most people don't realize, but McKenzie was the inventor of self-treatment as a discipline, as a concept. Mm. He invented the whole thing. Yeah. Mulligan and the Nordic people and Stanley Paris and all those people in the United States and Canada, they whatever self-treatment they did was basically borrowed from McKenzie.
I see. I was actually about to ask you the question: how different, in your eyes, are the Mulligan techniques and the McKenzie techniques? Are they complementary? How different are they?
Well, I was thoroughly trained in the Mulligan system as well. I mean, obviously, yeah. Not just he taught his own techniques as well as the Nordic system. And I went and I helped Brian Mulligan as an instructor right up until the mid-1980s. Mm-hmm. And so he was teaching his own stuff then, the nags and snags and all those PRPs and all those things that he did. And but I was never a Mulligan instructor because by then I was convinced that the patient ought to do as much as they can for themselves.
Yeah.
As to me, McKenzie had, I'm using modern words now, but McKenzie's idea was the beginnings of the application of cognitive behavioral therapy to manual therapy, to musculoskeletal diagnosis and treatment. Get the patient, self-efficacy was a word that McKenzie and the faculty of McKenzie introduced to physiotherapy. Mm. And the whole idea that it's the old story, you give a man a fish, you'll feed him for a day, but you give a man teach him how to use a fishing rod and you'll feed him for the rest of his life. Yeah. That was the principle behind the McKenzie approach. And that began with him. And by the way, I still practice very, very similarly now. And it doesn't matter. There are many things about what the McKenzie Institute are teaching now that I actually disagree with, but that doesn't matter. The contribution that McKenzie has made to our profession is immeasurable. Mulligan and these other manual therapy teachers have taught us many, many useful techniques and procedures. They have encouraged diagnostics, and they have done lots of things like that, which are very, very good. But in terms of fundamentals, I think McKenzie has done more.
Okay, got it.
So anyway, I continued to practice until I had 2 large clinics in Auckland. One was a specialised from 1991 through to 1998. I opened up the first special spine care clinic in Auckland. And the reason was because I was seeing far too many really difficult patients, and the funding model for that by the government was just not enough to pay for the amount of time that I needed to spend with people, because I was seeing all these complex backs and necks. And so we set up a special spine care clinic. So we had a different funding model, and we didn't call it a physiotherapy clinic. It was just a spine care clinic.
So when you say funding, do you get money from the government, the social security system?
Well, it's a quasi-autonomous non-government organisation called Accident Compensation.
Okay.
And so that came into being in 1974 and is still there today. It's a state monopoly on insurance for people who have accidents.
Okay, only for people with accidents.
That dominates the funding of physiotherapy in New Zealand.
I see. But people with chronic lower back pain, do they get any refund?
Oh yeah, they get plenty of they have access to care.
Okay.
But we won't go into that. That's a mess.
Okay.
It's not something you want to know about, honestly.
All right. Maybe some other time.
It's been both a blessing and a disaster.
I see.
It's like the national health system in the United Kingdom. The Brits do not want to get rid of it, but they'll never get rid of their waiting lists.
Yeah, true.
You can't choose your doctor.
Yeah.
So, I mean, there are many things wrong with the NHS, but the Brits will never get rid of it. We have exactly the same conflict here in New Zealand with accident compensation. There are many things wrong with it. Really bad, really, really bad. It's not good for our profession in the last 20 years. But it actually funded the growth of physiotherapy in New Zealand in the 70s and 80s.
Okay.
Yeah, but that's another story. That's politics. Let's not go
let's put it aside for now.
Absolutely. Anyway, in 2001, I sold my clinics in Auckland and my nice big house, and I self-funded my own PhD. I had been invited to do a PhD out of a university in Sweden, and Professor Birgitta Oberg, who was generously asked me to come and do a PhD with her. And the reason why she asked me is because I'd already done the sacroiliac joint studies with Dr. April in New Orleans. And while I was teaching in Linköping in Sweden, I was teaching there, and she was sponsoring my courses. I was teaching the spinal courses, the McKenzie courses, and my own upper and lower extremity joint courses in Sweden. And I said to her, look, I've done the sacroiliac joint study. Now I want to spend more time with Dr. April and do more studies on the facet joints and on discs and stuff like that. And she said, well, if you're going to do that, you might as well do a PhD and you can come to Sweden to do it. And I didn't go to Sweden. I didn't live there. I sold my practices. I moved into a house I had bought and owned. My wife and I, our children all grown up. We moved into a 4-bedroom flat, and I did my PhD doing my research in New Orleans. traveling, going around the world about 3 times a year.
Wow.
To the United States to do the research, then go to Linköping in Sweden and to do the academic work, and then back to New Zealand to see my wife, and then back for 4 years. And
impressive.
Well, only for 2 years mostly, but I continued once I'd finished gathering data. Then, of course, most of the work was academic, and I was not seeing a lot of patients at that time. I was just working on my my data analysis and preparing papers and that sort of thing. And then when I finished my PhD in 2005, I didn't want to own a practice anymore. I'd done that for 30 years. And I got invited to come down here to Christchurch to work with a guy called Graham Nuttridge, who was also McKenzie faculty. And he agreed to pay me a salary, and I'd teach his staff and continue to see patients. And I was able to go and teach wherever I wanted to in the world and have time off. It was very, very flexible. And so I've been down here ever since. We have, for 20 years, we worked on our registration authority here in New Zealand to get specialist physiotherapists recognised as specialists.
Yes.
And we finally achieved that in 2019. That's only 4 years ago.
Wow.
I was already about to retire. I was 69. I'm 74 now. I'm 74 in a couple of days.
Oh.
Yeah. So I was 69 when we finally got recognised as specialists, and I was the first one to be registered as a clinical specialist, and paid the same by accident compensation as other specialists, medical specialists.
Okay.
So I decided to go back into private practice so that I could end my career actually being paid for the work that I did.
I see.
So I've been back in practice since 2019 as a clinical specialist.
Wow, what an impressive career.
Well, it's long. I mean, you quickly go over that and it sounds so brief, but it's not. It's been a long journey.
Yes. Very, very long, but very interesting as well.
Oh, it's been fascinating. It's been a great ride.
Yeah.
It's been a great journey.
So do you work by yourself?
I'm retiring from clinical practice this year.
You what? Sorry?
I will retire from clinical practice this year.
Will you?
Yeah.
Okay. Will you continue to teach?
Oh, yes.
Yeah.
And I'll spend more time on research. I've still got a lot of research projects I want to work on.
Are your research on lower back pain mostly?
Yes. I did my PhD on low back pain, and so really, although I feel very comfortable with any part of the musculoskeletal system, back pain is the biggest problem.
Yes.
Spinal pain is the biggest problem. And I'm not happy with how academia is treating back pain from a scientific perspective. I'm not happy with it at all. The concept of non-specific, you've watched my free video. The concept of non-specific back pain, it's a joke. It's an academic joke. You don't talk about non-specific chest pain or non-specific head pain. Why do we talk about non-specific back pain?
So what would you like to change then in academia to make it more efficient?
Well, what we have to do is to recognize the science. The science is very, very clear on back pain. It doesn't matter what you do, whether you are a manipulative therapist, a cognitive behavioral therapist, or you're doing CFT, or if you're doing movement analysis and all that stuff, manipulative therapies, acupuncture, prayer, nothing, pills, injections, nothing is any better than anything else. That is the fact. Right? We knew this in 1999, 24 years ago, 3 years ago. We knew this. Moritz von Tilda wrote a book It's right. It's in a box right there.
Mm-hmm.
He wrote a book doing one of the early analyses, systematic reviews of all the randomized controlled trials on low back pain at that time, and it's quoted in that lecture. All right, is that there is no difference between the treatments. Now, what that means, it's very simple. What it means is that either back pain is imaginary.
Yes.
It's not a real thing,
Mm-hmm.
or it is so many things that any given treatment can't possibly be effective on all of them. Now, which do you think it is? Huh? I mean, seriously, do you think it's an imaginary disease that people are imagining their back pain?
No.
If you think that, then you need to go back to school.
Yes.
I mean, you need to get off your postmodernist nonsense.
Yeah.
And actually get scientific.
Yeah.
The fact is that these patients come in having 40 years of age, never having had back pain ever in their lives before, living a full and natural, happy, productive and effective, active life, and suddenly they're crippled by back pain. Why? It's something is going on the back somewhere, and it's producing nociception, which will be variously interpreted by your brain and spinal cord as the experience of pain.
Yeah.
And and disability is a consequence of that. Disability is an effect. It's not actually a fundamental cause of anything. It's a consequence. All right. And pain is your experience of nociception, your conscious experience of nociception.
Mm-hmm.
All right. This is not rocket science. This is very, very simple stuff.
Mm-hmm.
I mean, you get people who make pain so bloody complex. You see these diagrams with a million things on them. Who can ever understand that?
Mm-hmm. Mm.
So even the people who write it don't even understand it.
Yeah.
All right. It's far too complex. It's not that difficult. It's in principle, back pain is a consequence, or back-related pain is a consequence of something going on inside. Now, you know what my history, probably as well as anybody, that I have a fascination for finding out where the nociception comes from.
Mm-hmm.
I've had that fascination since I was 20.
Mm-hmm.
So, I'm a leopard whose spots have never changed. But I am dealing with people, with individual patients. I don't treat populations. I treat individuals.
Yeah.
Now, one of the big mistakes of academia began in the 1980s, where they started to say, well, in the 1980s, this is before MRI, before diagnostic methodologies were even well established. They realized that a patient can come into the clinic and see 4 different doctors and get 4 different diagnoses. That was the Quebec Task Force on Activity-Related Disorders, published in Spine, Volume 12, 7S,
Yeah.
1987.
Mm-hmm.
All right, that was the first systematic review on back pain. And they didn't have the electronic services like we have today. They did this all by hand. All right. And they did this massive finding, and they found basically that, first of all, diagnosis is not reliable. Okay? Doctors can't agree with each other on the same patient.
Yeah.
All right? And so they said, well, okay, we have to take a different approach. And the different approach was, so what's the real problem here? Well, the real problem is that although most patients do improve and get better, a significant minority go on to have ongoing pain and disability. And low back pain was acknowledged as being the single greatest cause of disability in the modern world. Pain and disability. I think it was the second most, back then in the 80s, we knew there was the second most common symptom presenting to doctors, and second only to headache. All right, so we knew it was a big problem back in the 1980s. And the cost of it was it was already doing this.
Yeah, yeah.
And it hasn't stopped.
Yeah, it hasn't stopped.
It's still doing that.
Yeah, absolutely.
So all these changes that we've made haven't made any difference at all to the big problem, at all. So we're obviously doing something wrong.
Mm-hmm.
We haven't affected this trajectory of increasing cost and disability at all. Not at all. So what has happened since the 1980s? Well, first of all, they first started off by looking at what are the predictors of chronicity?
Mm-hmm.
And they did the research. A lot of people from Scandinavia and Europe did a lot of research, and also in the United States and Australasia. And they found that the only predictors of a poor outcome were psychosocial. So all the work except for a very small amount, 90% of the research then shifted dramatically away from pathoanatomy into the psychosocial.
Mm-hmm. Mm-hmm.
And that's been going on all through the 1990s, all through the 2000s, and now 30 years later, the majority of research has been done is all on psychosocial stuff. You know, they invented the word biopsychosocial, right? Okay. And this is not new. That was in the early 1990s. We all embraced it, every one of us. All right. But we had no doubt that there was a bio. The psychosocial is what influences recovery.
Yes.
It isn't the cause of pain.
Yes, absolutely. Mm.
Okay. There is a cause of nociception that is being affected by the psychosocial things that results in persistent pain and disability. And now, those of you people who have been trained only in the psychosocial and very little in the bio, okay, think that you can suddenly make pain happen spontaneously out of nowhere. That does happen, but that's a psychosis. It's not routine back pain.
Yeah.
You know, just because you've got a rubber hand and you hit a rubber hand and somebody goes, ow, that doesn't mean you can create non-existent pain out of nowhere.
Mm-hmm.
That's a trick.
Mm-hmm.
That's a trick. It's nothing more than a trick.
Mm-hmm.
You know, it's like, you know, you get a potato and you put a straw against it. If you push it in, you break the straw. But if you go bang, you can drive that straw straight through the potato. Mm-hmm. It's a trick.
Yeah.
It's a game. You know, you don't fix a nociceptive source of nociception by fiddling with the mind and fiddling with behaviour. It doesn't work. And what's more, if it did work, you would be starting to see some change in the trajectory of increasing disability and pain in society. We're not seeing that. We've been desperately trying to do this for 30 years. It's not working.
So as physiotherapists, where do we stand?
Well, no. We stand exactly where we stood all through this time, is that we have to understand the science.
Yeah.
The science is being dominated by statisticians who believe that the only way that we can manage back pain is by influencing risk factors and epidemiological issues. So in other words, we know that you're at risk if you don't like your boss at work, or if you're unhappy at home, or if you are depressed, and or you there's a welfare state that's picking you up and giving you the opportunity to have lots of time off work for no cost to yourself. Mm-hmm. All right. We have all these psychosocial economic things which are the driver of the increasing costs. All right. Now, so what we've got to do now is, our focus is to try and manipulate people's behaviors and their beliefs about pain and their cognitive errors and all these things, which are all true. I mean, these are real things, but it doesn't fix the back pain. The only small little thing that might have shown that this approach to back pain actually is successful is Peter Sullivan's cognitive functional therapy. He has shown that that you can actually make a pain to change pain as well as disability, but it's not big. It's small,
Mm-hmm.
and only on the most chronic people. Now, the vast majority of back pains we see are not people who've had pain for 10 years.
Yeah.
The vast majority of people have had pain for less than 3 months or 6 months.
Yeah.
So it doesn't apply. You can't take a bunch of people who have had chronic pain for years and years and years and are chronically off work and say, look, we do this cognitive functional therapy thing and we get a good result. And it is a good result. I'm not disputing that at all. All right. And then apply that to the person who walks in with their first episode of back pain. It doesn't work.
Mm-hmm.
We have to be absolutely frank and honest. And I've had this discussion with Peter. Peter's a good bloke. I like Peter. And he's a very, very impressive presenter.
Peter, can you repeat his name?
Peter O'Sullivan.
Oh, yes, O'Sullivan. Mm-hmm.
The cognitive functional therapy, that's his word.
Mm-hmm.
That's his change from cognitive behavioural therapy.
Yep.
He's made it a physiotherapy thing instead of a psychological thing.
Okay.
Which I think is appropriate, by the way.
Mm-hmm.
And certainly is a good system for people who are in pain clinics, for patients who are presenting to pain clinics.
Mm-hmm.
But for the average physiotherapist out there, just being functional in the way that he does it, I don't believe is actually that successful.
Okay.
That's my personal belief. And Peter may well argue differently, and that's fine. And I'd be delighted to always have a conversation with Peter. He's a good bloke. So here's the thing. We know that back pain can be caused by a multitude of different things. All right, that the actual origin of nociception can be the disc, the facet, the sacroiliac joint. It can be nerve root involvement and things like spondylolysis and spondylolisthesis and stress fractures and the vast majority of these things, there's about 5 or 6 sources of pain that produce 95% of all the back pains. The other 5% are the cancers and the infections and all those.
All the red flags.
Yeah. So 95% are things that we know about. We know actually cause back pain and back-related pain. Okay, so the question is, so what is the cause of these things producing nociception? All right, so we know that discs can be painful, but why are they painful? Now, we now know that actually that people who have pain coming from the anterior column, that's the vertebral body, the end plate, and the disc, probably constitutes 50 to 60% of all back pains.
Yeah.
All right, but we know that it's not just one single pathology. We now know from my own research that a substantial proportion of those patients show directional preference and the symptoms can be made to centralize. So I call that mechanical discogenic pain. And I have my reasons for that, which we won't go into because it doesn't matter right here. But I call it mechanical discogenic pain because it behaves in a mechanical way and it follows the same patterns that McKenzie has talked about all these years. All right. But if you move them in one direction, they get worse and worse and worse, and their symptoms can peripheralize. Yeah. Then you move in the opposite direction, and the pain goes the opposite direction. It gets better and centralizes. And the only thing that I have added to McKenzie's original idea is that I now, to classify a person as being a centralizer or a directional preference, is that it has to be reversible and repeatable. In other words, you have to be able to take the pain away, bring it back, take it away, and bring it back like a yo-yo.
I see.
If it's truly reversible and repeatable, that is mechanical discogenic pain, and you know exactly what to do with it. You know what makes the pain come on. You can teach the patient, this brings your pain on, this takes your pain away. This brings your pain on, this takes the pain away. Don't do that, do lots of this. It's really simple.
Yep.
Okay, that's basic McKenzie. Now, it doesn't matter whether it's flexion or extension or any combination of movements. All of those things, the McKenzie Institute people teach that perfectly.
Yep.
All right. And so you don't need to learn that from me, although you can. All right. But the point is the McKenzie Institute people know, but that's what they do.
Yep.
And they're very good at it. All right. So that's fine. Then you have the other people who don't centralize. Now, that's one of your questions in your list. What do you do with the people who don't have a directional preference?
Yes.
Now, that's all the rest of those backs. The people with facet joint pain, the people with sacroiliac joint pain, the people with stress fractures, the people with prolapsed discs where there's extruded material pressing on the dura mater or the nerve root. All right. What do you do with those? Well, those are subsets. Now, here's something that will blow most people away. Did you know that there is no known conservative treatment that is successful for facet joint pain?
Did you know that there is no known treatment
for confirmed facet joint pain? There's nothing in the literature. Do you know there's one randomized controlled trial of a conservative treatment versus another treatment on facet joint pain? One. And it's not controlled properly. It's not blinded. It's a lousy study.
How come?
There are no randomized controlled trials on patients with confirmed facet joint pain of any consequence. Zero.
How come?
Because they're not doing it. They're doing all these studies on non-specific back pain, not specific back pain.
So what do you mean by non-specific?
No, I haven't finished.
Okay, sorry. I'll let you continue.
Do you know that there are zero studies on conservative treatments for proven sacroiliac joint pain? Zero. None. There's no research. There's no evidence. So anybody who asks me the question, can you prove that having a diagnosis is effective? The answer is absolutely not.
Yeah.
How can I? There's never been any studies. Mm-hmm. Zero studies. Now, where's the future of research for back pain? The answer is, let's start identifying patients with known sources of pain and seeing what the subsets of those are. So facet joint pain is not a single condition. Mm-hmm. You can sprain that joint. It can become osteoarthritic. It may be subjected to some rheumatic condition. There are subsets of that subset. Now, there's no treatment to cover all of those things. You can't there's no good treatment, single treatment. There's only one single treatment that is effective for facet joint pain, and that is radiofrequency neurotomy.
All right.
It does work. It does work. And there is evidence to prove that. But all that does is it kills the nerves that supply the joint. It doesn't treat the problem.
For those of you who don't know, can you explain what is facetal pain? Because until I saw your video, I never heard about it. There's a proof.
Sorry, what are you asking? What's the question?
What is facetal pain? Can you define it?
Facetogenic.
Facetogenic.
The pain arising from the facet joint.
Facet joint, yeah. And
that's the zygopophyseal joints, yeah.
And how do people perceive symptoms? Are they located in one specific area?
They get back pain.
Like a normal back pain, yeah.
Well, no, their back pain is usually unilateral.
Mm-hmm. Yeah.
And it can refer to the buttock, and it can sometimes cause symptoms in the leg, but mostly it's dominant back pain on one side. Okay, but the disc in the sacroiliac joint can do the same.
Yeah. Mm-hmm.
Right. So the only way that you can confirm that a person has facet joint pain is by doing diagnostic blocks to the joint, and there is a well-established protocol to do that. And I work with doctors who do that here in New Zealand, and I've been working with doctors doing those things since the mid-1990s. All right. Now, so I can tell you as a manual therapist, a conservative therapist, all right, I'm not an interventionist. I'm a manipulative physiotherapist, a McKenzie practitioner, okay? I can tell you that I have never successfully treated a patient with proven facet joint pain.
Okay.
With manipulation, with mobilization, with exercise, posture instruction, acupuncture, or anything else. Never. Mm. Now, I have had some successes, but I cannot honestly say to you that it was what I did made the patient better.
I see. Okay.
And and I have to tell you, I feel the same way about sacroiliac joint pain too.
Mm-hmm.
So in other words, you have those are just two categories, subcategories of the non-specific back pain spectrum, where I believe that conservative treatment doesn't work.
So just to summarize so that people can really understand, in the non-specific lower back pain, we have different categories. We have the facetogenic pain,
Yes.
sacroiliac joint pain,
Yes.
discogenic pain.
Yes. And vertebrogenic pain now. That's something that has emerged over the last 10 or 15 years.
Mm-hmm. Vertebrogenic pain. So when vertebrogenic, which is the most common of all these categories?
Well, when I teach that when I don't talk about just discogenic pain anymore. Back when I did my PhD, that is all we thought was there. We thought that the disc was the cause of most of these pains coming from the anterior column.
Mm-hmm.
The anterior column is all of those structures anterior to the spinal canal. Yeah. And that includes the vertebral body, the end plate, and the disc. Okay. Now, we were doing discography. We were injecting the discs to see if they caused pain with a negative control and all those things. If you read my papers, it's all there. But what we now realize is that when you pressurize the disc, it also distorts the end plate. So if you have pain coming from the end plate, which is a vertebral source of pain, then that is produced by discography as well. So we now know, with the work done by Hane, Albert, and colleagues on modic changes, that modic changes are the MRI evidence of end plate pathology. Now, we also know that not all of those are symptomatic, but they can be symptomatic.
Mm-hmm.
All right. And so we now know that that if you have people with modic changes that are symptomatic, that it is the modic changes that are most likely the source of nociception. Or the modic changes are the changes you see on MRI. The pathology that produces the MRI image is what is producing the nociception.
Mm-hmm.
So that's not discogenic pain, that's vertebrogenic pain.
Mm-hmm. Coming from the vertebrae.
So, well, it's from the end plate and the vertebra. Yeah. Now, there is a treatment for that now. It's called vertebro-basilar nerve radiofrequency neurotomy.
Right.
Ablation. It's a relatively new thing. So the last 2 or 3 years.
So what does it do exactly?
Well, what they do is they drive a needle into the side of the vertebra, into the middle of the vertebral body, and then they do radio frequency neurotomy. They kill the nerves in the vertebra itself that supply the end plate and part of the disc. And so it's like doing radio frequency neurotomy to the facet joints, but it's done to the anterior column.
I see.
And so that treatment is actually quite successful.
Yeah.
And it actually does work. I have many issues with that treatment. As a conservative therapist, I don't think it is appropriate for a lot of people. All right. For example, for a person who's aged 20 years of age, you don't go ablating the nerves to that structure in a young person, because you don't know what that's going to do 30 years down the track. But if you're a 50-year-old or a 60-year-old with chronic pain coming from there, then it might be a perfectly okay thing to do. So there are issues with that, but we now know that the vertebral body is a source of pain. We have known for many years that the disc is a source of pain since the 1950s, actually. All right, but we didn't know until the 2000s that the vertebral body was a significant source of pain as well.
Mm-hmm.
Now, those modic changes, we don't know. They're not all the same. All right. Some seem to be caused by an infection, and some don't seem to be an infection at all because they don't respond to antibiotics. Some do respond to antibiotics and some don't. So there are multiple causes of these pathologies which you see on MRI. So where does physiotherapy fit into all that? Well, in my opinion, physiotherapists are the best people to learn how to do the diagnostics. Not the interventions, not the injections, but the clinical workup. We know how to move people around. We know how to physically examine people and say, this person has directional preference, conservative care is going to work for that person. The chances are very good. And you mix that conservative, directionally specific treatment with rehab and graduated exposure to load and all those things that we know how to do better than anybody else. There's a group of people out there that we can identify, we put them over there. Then there's this group of people that we know physiotherapy does not work for. And we find out if they've got facet joint pain, and we can identify those people, I believe, with significant confidence. People with sacroiliac joint pain, people with vertebrogenic pain that is not directionally specific. Now, we can then be involved in the process of managing those patients. And that management could be by injection, by surgery, by cognitive behavioral therapy or functional therapy, by pain relieving techniques such as medications or acupuncture or whatever. But we're not attempting to treat the pathology because we know that there is no conservative care that actually works.
Mm-hmm. Yep.
But we may be involved in their care, but we're not the agent of change as such. It is the patient and often interventions that are going to work. That big group of people who are centralizers and have directional preference, we are the agent of change there. No question about that at all. Those patients whose pain can be made to centralize, we know what to do with those. We've known how to deal with this for 40 or 50 years now. All right? And we're good at this. We are really good at it. All right? But the other maybe 50% of back pains, all right, we will not be effective on.
Are you saying that do you think that we can still test those patients, the non-specific lower back pain types of patients, by trying to centralize them at first because we don't have no other way to diagnose?
Well, that's one of your questions is how long do you persist?
Well, yes.
How long do you do you see the patient every day forever? Or
yes.
No.
Is it enough after first session after doing multiple repetitions?
No, it's not. No, the first session, you'll identify the easy centralizers, the people who clearly have a directional preference. You'll find that out in the first session with many people.
Yeah.
All right. But then there's a group, a relatively small group, but a group who need a week or two of working hard to get that effect.
Mm-hmm.
So depending on the individual factors, sometimes I'll see the patient on a daily basis. Sometimes I'll see them in 2 or 3 days after I first see them. Sometimes I'll see them a week later. But I will see them soon.
Yes.
All right. And to make sure that they do not have a directional preference. If they do have a directional preference, then they get physiotherapy care, which will be in the standard McKenzie type of model. If they're non-centralizers, then we have to make a decision as to what the treatment will be.
Mm-hmm.
Are we going to send the patient off for diagnostic investigations to find out where the source of nociception is? Or are we going to treat that patient functionally because it's minor symptoms? We don't want to do invasive things to these patients. If they have minor symptoms from the facet joint or the sacroiliac joint, we don't want to do injections. We don't want to do surgery. We don't want to do people who have minor symptoms. We don't want to do that to people with minor symptoms. So we manage those people from a cognitive functional therapy perspective, which I think is a very sensible thing. Mm-hmm. People sometimes have to learn to live with some pain too, and we are good at this. Physiotherapists can be very good at this. Mm-hmm. A mixture of medication and proper approach to pain works with these patients, I think, very well. Mm-hmm. And the patients may not get a lot less pain, but they maintain their function, they maintain their mental health, and their involvement in life, and they can continue to look after their kids and and be active and play sport and go to work and need, even though they have a bit of pain. That's not a problem. Pain is often something that people have to accept. And if you get to my age, if you haven't got pain, you're a rare beast. I have pain, but it doesn't stop me. Well, it does, but, I don't do as much as I used to do because I've got a stiff neck. I'm getting old,
Yeah.
So, but I don't beat myself up because I've got a bit of neck pain.
Yeah.
All right. In other words, I've done cognitive functional therapy to myself.
That's right. Yeah.
I mean, I've got facet joint pain at probably 2 levels of my neck. All right, and it's I could go and have radio frequency neurotomy to that, but it's not really necessary. It's not giving me constant headaches, and I'm not in pain all the time, and it's not it does sometimes disrupt my sleep, but not badly.
Yeah.
I live fine. I don't need that other stuff. I occasionally, if I do something silly and I have a sore, it's bad for several days, I take some anti-inflammatories for a few days and it settles down. I'm fine again. It's these are okay. So in other words, physiotherapy isn't this or that, and that's it. The world isn't like that. Patients are not like that.
La deuxième partie de cet enregistrement sera disponible dans le prochain épisode, numéro 27, la semaine prochaine. En attendant, n'hésitez pas à vous abonner, à liker, mettre 5 petites étoiles et à partager cet épisode. Et je vous dis à bientôt.